The first talk is going to be on the right patient selection for PC IOLs criteria and need by Dr. Anurag Mishra. We are going to be hearing about a new intraocular lens which has come, which is the Vivinex geometric intraocular lens. So over to you, Anurag, for your talk.
Achha, Anurag, there are three questions to be answered in your talk. As per the information here, what are the right patients at the surgical pulse? What are the preoperative exclusion criteria for PCIOL patient selection, biometry, diagnostics, pulse in selecting the PCIOLs? So Dr. Anurag is one of the superb orators and a good teacher, and definitely going to learn so many things today. Dr. Anurag, please start.
Thank you so much, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. So we'll start straight away with the patient selection, and of course, the patient selection will not be proper if you do not have the right kind of gadgets to look the patients through and diagnose these various issues that actually make them unsuitable. It's very easy to find the patient suitable. It's more difficult to find the patient unsuitable, particularly when you're talking about ATIs like the trifocals. Let's start with refraction, the basic refraction that we see in the OPD. We have to see whether the patient is myopic or hypermetropic previously, and there's a pre-existing astigmatism or not, based on which we see whether the patient is qualifying for a non-toric or a toric platform. Previous glasses and refraction reports, if any, we have to keep in mind that the total refraction the patient is using in the form of glasses could be a combination of corneal astigmatism and lenticular astigmatism, so that must be kept in mind. Anisometropia and chances of amblyopia have to be kept in mind, and they can be ruled out with a simple test of RAM, and it's a very inexpensive equipment. We can all keep it in our OPD to see what is the retinal acuity that we are likely to retrieve after the surgery. So this is just one interesting example that I wanted to show everybody. The autoref readings, as you can see, show plus 4.25 and minus 4.25. This might show that the patient has refraction, patient needs glasses. However, this is also likely to come after a trifocal implant where the patient actually does not need any glasses. It's because of this diffractive rings, the AR shows bizarre readings like this at times, but when it comes to the acceptance front of the patient does not accept anything. So there's no reason to jump off the moment you see that on the AR readings. Right, so let's come to the image guidance, because that is something that gives us a very good feedback into it. Now we have the advent of another machine called Argos, which combines image guidance with biometry. And there are two USPs of that machine which we would like to talk to you about. Normal biometry machines take one refractive index as the reference refractive index of 1.3375 when they measure the axial length. But what we have to remember is the light travels through different tissues at different speeds based on their refractive indices. This machine identifies that, splits the refractive indices into cornea, aqueous, lens, and vitreous, and calculates the axial length according to the light that travels through the tissues in different speeds or varying speeds. The other USP it has is in very dense cataracts, it has an ERV mode, an extended retinal visualization mode. In the normal mode, the axial length that calculates is from the corneal vortex to the posterior capsule. In the ERV mode, it calculates the distance between the posterior capsule and the center of the fovea, and then it stitches them together to give us the complete axial length. So it has the propensity to calculate the axial length even in the densest of cataracts. And then you can cross-check whether the lines align or you have to retake them. So this is one feedback. This is the image guidance system. The yellow line always comes in when the residual astigmatism is more. It is shaded green when the astigmatism is acceptable. It also gives you to the toric model, whether T3 or T4, and it also adjusts according to the SIA that you feed in. Even if you don't calculate your SIA, you can just put in the incision size, whether it's 2.2 or a 2.8, then the machine calculates the toricity values for you. The maximum number of inputs that come in towards an ATIL practice perhaps comes from the eye trace, the aberrometry that we have in the industry. And what does it show us? This patient, for example, wanted a trifocal, but we could not give it to him. As you can see, the angle alpha is very high, staged at 0.605. So no IOL is there in the market, which has a central bullseye of more than 1.2, with 1.2 being the maximum. So this patient perhaps is unsuitable for a trifocal implant, so it's shaded red. The other thing the patient, the machine gives us is the second and third order aberrations. If the coma and the trefoil from the cornea are high, the image is already distorted. So you don't want to distort the image further and reduce the contrast sensitivity post-operatively by putting in a trifocal. So these patients are also unsuitable for trifocals. The next example we see is that the spherical aberration from the cornea is very low. It's staged at 0.125, and the total spherical aberration coming out of the eye is 0.026. So you have to carefully choose the IOL that you're going to fit in. In my opinion, this patient should be given actually a spherical IOL, not even an aspheric IOL, which reduces the positive spherical aberration. Because if I have an example of a patient, this patient had a spherical aberration of minus 0. This is a post-operative scenario. Spherical aberration of minus 0.410. We never knew why the patient is dissatisfied. The patient came back to me repeated number of times and said that my image is not crisp, it is not clear. Unless we put him to this test by eye trace, we found out that the spherical aberration was low. And when we plotted the DLI, we saw that the image is not very clear. This is the corneal image which is coming, which is pretty sharp. But from the internal side, since the spherical aberration output was on the negative side, there was some sort of image distortion coming as an output. This is another example wherein the internal higher order aberrations are very distorted. The cornea is doing fine, but the internal distortion is too much there. And when that happens, then you suspect a lens tilt or a dislocated or subluxated lens. Although it is not clinically evident to you, the machine shows that this is a lens tilt and perhaps not very ideal. This is a perfect example. The angle alpha within normal limits, these sort of distortions happen in normal cataracts as well if the cataract is very dense. And the delta is also doing pretty fine. So perhaps this patient qualifies for a toric implant, but a toric trifocal can be given in this. But the other interesting thing in this particular patient is, if you look at the refraction, it takes it from different zones. So as you go down from 3 millimeters to 2 millimeters, look at the astigmatism that drops from 2 millimeters to 3 millimeters from a value of minus 5.47 to 2.24. So this is a classic example of anterior lenticonus, wherein the central part shows you the maximum amount of astigmatism. When the scan size goes wider, the astigmatism comes down because it's a cone right at the center. This is a good MTF curve. This is another thing that the machine shows you, the modular transfer curve coming out of the retina. This is a critical curve that is there, the critical square that is there down below. If the line is above that, then you know that the contrast sensitivity coming in from the cornea is good. And this patient qualifies for a higher order IOL, for an ATIOL practice. But if the MTF falls below that line and shades somewhere in this square, then this patient does not qualify because the contrast sensitivity is already reduced from the cornea. You don't want to reduce it further by putting in an ATIOL. So this is an unsuitable MTF curve. Some of the times when you subject the patients to specular microscopy, you see that the hexagonal cells stand at 0 and they have very distorted images. So they are also, in my opinion, not suitable for ATIOL practice. So you better avoid these patients because they are going to have post-operative indices which are low too. The most important feature apart from a proper biometry perhaps is the pupil size, and for me there is a cutoff of 3.5. The pupil size should not be more than 3.5 in a scotopic and less than 3.5 in a photopic condition, because when that happens, then there is a lot of image distortion. So the pupil size has to be kept in mind. This particular example, the pupil size is 2.8 in low mesopic pupil, so it is not qualifying. And in the other patient example that we see, I mean, you can of course measure the pupil with different instruments if you have access to them. The other example is this. This measures 3.95 in a photopic condition, also unsuitable for ATIOL practice. Also, the pupil size can come from the anterior coming in from Heidelberg. This is a refraction map and the amplitude of accommodation. As you can see, this is testing the right eye, and the refraction values on the center is minus 2.25. This is when the patient is accommodating. This is where the patient is not accommodating, not inducing any myopia, but the refraction map is pretty stable. Very ideal candidates to receive an ATIOL, particularly in trifocals. Whereas in this, there is some amount of image distortion that is happening the moment the patient is trying to accommodate. This is a post-operative scenario. And this is very unsuitable as a refraction map because there is a distortion when the patient is trying to accommodate. Even without the accommodation, also the patient is having some sort of distortion as the refraction map. Now coming to the trifocal in question, as Professor Tetial so elaborately discussed in the beginning, this is an IOL called Geometric that comes from the house of Hoya surgical devices. This is one example wherein both eyes have already received trifocals. Look at the effective range of accommodation that is happening, effective range of focus that is happening there. It's 2.44D. There's no reason that this patient should be dissatisfied. He has very good distant vision. He has very good intermediate vision. He has very good near vision as well, because the range of focus ranges to 2.5, almost normal. Bilaterally, he has received another trifocal IOL, which is not from Hoya. But the patient is very happy. I have no complaints against the patient, does not complain of anything. But this is another example where one eye has already received geometric. That's the eye shaded in pink, the left eye. The right eye is about to receive it. The right eye is unoperated. The difference between the previous DOF curve and this DOF curve, which has received geometric, is the depth of the effective range of focus, as you can see, is still 2.35. That is doing pretty well. But in the previous curve, the highest peak of the curve was lying somewhere at around 0.5, 0.6 range of logmar. In this, the peak is very sharp and it goes right next to 1, which is excellent visual quality. So this is what I have found in my practice of geometric, whatever implantation I have done. All the depth of focus curves behave this way. The peak is very sharp, the quality of vision is excellent. They do not encounter any halos or glare in their practice. So this is the DLI of the same patient coming in from the left eye. You can look at the image that comes out of the cornea from the internal and the total output, very crisp and clear vision. This is another trifocal. The patient was not complaining anything, but if you subject, just for the sake of comparison, if you subject them to the DLI index of the eye trace, there is a distortion that is coming in. However, I re-emphasize the fact that the patient was not complaining anything, but you do see a distortion and you can clearly demarcate the difference between the two IOLs. The anterion gives us a lot of things, including the topography and the total corneal power in post-refractive cases, and an idea into the lens tilt where the axes do not match the axis of the eye and the axis of the lens. It gives us the excellent industry-leading ASOCT pictures from which you can know what type of cataract it is, posterior polar, communicating, non-communicating, and hypermature liquid-filled pockets, all that. Specular microscopy gives us a true picture of the specular cell count, and as we discussed minutes back, if the hexagonal cell percentage is too low within low endothelial cell count, we should be staying away from at least planning a trifocal in those patients. Then the ocular surface has to be evaluated. If you have access to a dry eye suite, fantastic. This patient, for example, had very low lipid layer content standing at 57 and 55 preoperatively. The patient had come ready for surgery, but we sent the patient back with treatment with antibiotics, warm compress, and ointments. After 3 weeks, the patient came back. The lipid layer was doing pretty well, ranging up to 100%. And then we repeated the biometry and took the patient off for surgery. What happens in a biometry is that the keratometric Mayas do not come properly. So it actually distorts, particularly if you're planning a toric implant in that patient, it distorts the delta value in the repetitive examination. So it's important for us to go back to the biometry sheet, the printout, and cross-check whether all the Mayas came properly or not, sharp or not, so that we don't miss out on the astigmatism, total astigmatism that is to be corrected. So in a nutshell, that's all I had to share with all of you, ladies and gentlemen. Thank you so much for the opportunity, Chair.
Thank you, Dr. Anurag. I think you highlighted all the important points. And in terms of, you talked about so much of aberrations and the assessment by eye trace. Many people may not have access to eye trace per se. For a general people, what should be the guideline to, have a proper selection is all right for getting, not putting them into a premium IOL. Suppose they don't have eye trace also.
So the angle alpha is something that many machines calculate nowadays. Angle alpha, not angle alpha exactly, but chord mu is something that many machines calculate. Even if they don't calculate it, they'll give you cross marks, and you can have a rough estimate from there. Where is the chord mu going, and how likely is it to have an off-axis placement? The idea is the center of the pupil has to be at the center of the bullseye that the trifocal has. Apart from that, the dry eye is something we can easily exclude in the OPD by various techniques, various simple measures. The aberration profile is, of course, something that has to be looked at with an aberrometer only. If you don't have access to it and you're planning the trifocals, in particular, and in my opinion, I think one should get in touch with the center which has access to the machine and maybe evaluate the patient properly before planning so. But these are the basic things which one can do at the office, even without having access to such high-end equipment.
Okay, thank you, Anurag. Dr. Bhavika would like to add something on a pre-selection wise.
I think profile of the patient is also to be taken into account.
Dr. Mahipal, sir?
So I think what he has highlighted is preoperative ocular surface is something which is important. Biometry being bang on is something important, and obviously psychology, which he has talked about, and where would the IOL center is also something important. But I think with the present generation of trifocal lenses, the incidence of adaptability and neuroadaptation has gone up very significantly. The complaints have gone down, and whatever technology they have used to smoothen out the ridges that are there, I think that has helped significantly. And I think somebody will be talking about two different types of lenses that they are getting, which is the geometric, which you can have different light distribution between intermediate and near.
Yeah, I
So,
think I think Anurag did cover all the
yeah.
aspects, like right from the ocular surface to specular microscopy, then looking for the aberrative profile of the internal aberration versus corneal aberrations, looking onto the thing. The other thing nowadays for a cataract surgery per se, it has become very very important to assess the posterior segment also. Maybe a OCT of a macula should be assessed. Sometimes you do have some sort of a epiretinal membrane or some traction, something, especially people suffering from other diabetic other things. So routine examination, posterior segment should be a part of your examination also for all cataract surgery patients.
So in our case, we have a standard of doing IOL master, specular, and OCT in
Yes.
all cases.
Yeah,
What we
I think that has become the standard
yeah.
for all cataract